On behalf of the American Heart Association, I would like to welcome you today to the Modeling Success Real-World Approaches to Recurrent Pericarditis Management webinar. My name is Sue Abelt, and I'm a Senior Program Consultant with the American Heart Association. Thank you to our presenters and attendees today for your time and dedication, and we really hope that you leave with practical insights on this very important topic. This event is made possible through the American Heart Association's Addressing Recurrent Pericarditis initiative, which is nationally supported by Kiniksa Pharmaceuticals. This is a multifaceted effort to improve diagnosis, treatment, and the quality of life for patients experiencing this disease. Through this initiative, a cohort of 18 healthcare champions are participating in a 3-year learning collaborative to identify gaps and barriers in care, gain deeper insights into the patient journey, and develop standardized practices that can be shared and scaled nationally. We encourage you to visit the website listed on the slide to learn more about this initiative. Before we get started today, I'd like to go over how to participate in today's event. All attendees are in listen-only mode. There are no CEs associated with this webinar. If you happen to experience technical difficulties, please try refreshing your browser. To access captions, you can click on the closed caption button found on the screen. Please feel free to ask questions by typing them into the Q&A box located at the bottom of the screen at any time during this webinar. You can find the PDF of the slide presentation. This will be available in the chat function. And recordings of this session will be available in the Zoom platform following this event. Please note that the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA-ASA, and the AHA-ASA does not endorse any product or device. I am pleased to introduce our presenters for today, Dr. David German, Dr. Dor Lotan, and Jordan Lindekins. First, we have Dr. David German. Dr. German is an assistant professor of medicine at Oregon Health and Science University within the Knight Cardiovascular Institute. He specializes in general cardiology and in the treatment of pericardial diseases. In addition, he is cardiovascular imaging specialist, focusing on echocardiography, nuclear imaging, and cardiovascular computed tomography. He completed his undergraduate education and subsequently a master's degree in public health and epidemiology, an MD at Tulane University in New Orleans. He came to OHSU for residency training in internal medicine and fellowship training in cardiovascular medicine, and he has been on faculty at OHSU since 2021. Dr. German, thank you so much for being here. I will now hand it over to you.
Thank you, Susan. Thanks so much for that introduction. And thank you all for the opportunity today for me to share with you what we've been doing at OHSU in Portland, Oregon. Oregon Health and Science University, OHSU, is a medium-sized academic medical center located in Portland, Oregon. It's the sole academic medical center for the state of Oregon, which covers a large geographic area, and about 98,000 square miles is the state of Oregon. But we also serve patients throughout Southern Washington and Northern California. And we have sort of a unique campus. You can see here in the picture, we have a hospital up on the hill overlooking the city in Mount Hood, but our outpatient clinics are located down at the riverfront with a gondola or tram connecting the two, which makes for a very nice commute. As you know, pericardial diseases include a wide variety of conditions, ranging from acute pericarditis to recurrent and chronic and constrictive pericarditis, as well as other conditions such as recurrent pericardial effusions. Caring for patients with pericardial disease is complicated and in many cases challenging, requiring at times frequent patient-provider contact, and access to multimodality imaging, multidisciplinary care, and therapeutics that require a significant amount of additional work and attention to care. The American College of Cardiology recently identified a need for pericardial disease centers to provide this sort of more complicated multidisciplinary care. And so we began actually in developing our Pericardial Diseases Center several years ago in 2022. And so I'm pleased to share with you our efforts. Initially began as my personal interest to create a clinical home for these patients with complicated pericardial diseases, and with an aim of increasing multidisciplinary collaboration, increasing access to advanced imaging and therapies to improve management for these patients, with the hopes also of documenting changes over time in referral patterns and therapeutic strategy, as well as bringing national initiatives and research opportunities to OHSU in this area. To bring this description today, I conducted a review of our correspondence related to developing our program over the last several years, as well as a review of the medical record document changes in volume and care. Prior to our initiative, our efforts at OHSU, patients with complicated pericardial disease at our institution might be managed by any one of the cardiologists at our institution. But typically biologic therapy being managed by rheumatologists. And in many cases, patients with pericardial disease might also be managed primarily or solely by a rheumatologist at our institution. And there was not necessarily any clear focal point or clear home for these patients. Their care was relatively fragmented, and there were no standardized care pathways or imaging protocols. When we began our efforts, it began as a designated focus area within our general cardiology clinic. And we started having our referrals within general cardiology that were identified as for referrals for pericardial disease being routed preferentially to me and our pericardial disease clinic, nascent at the time, and began identifying partners within cardiothoracic surgery and rheumatology. Initially had a small volume of patients, and also at this time started to develop some initial care pathways, clinical templates, and patient education materials. The following year, clinical volume grew. Multiple growing numbers of patients began to be managed on biologic therapy, and our nursing staff within our general cardiology clinic assumed a greater role in the care of these patients, particularly around prior authorizations, appeals, patient education, and training. And we also, during this time period, collaborated more and more with our cardiothoracic surgery team on on our pericardiectomy surgeries. And then in the last 2 years, we've had further growth. We've joined the AHA's Addressing Recurrent Pericarditis initiative. We've had additional collaboration with the cardiac imaging partners to refine and document our cardiac MRI and echocardiography protocols. And we've had increasing case complexity. We have more recently recruited a clinical pharmacist to help with management of biologic therapies and tracking of these patients, and then also begun standardizing in a more rigorous way our care pathways for management of pericarditis and follow-up of the patients. And we continue to do outreach regionally to increase awareness. Through all of this, our volume has continued to grow of our complex pericardial disease patients, as well as patients on biologic therapy. And none of this would be possible without our growing team, which includes our schedulers who make a lot of this possible, our clinical research team, our colleagues in rheumatology and cardiac imaging, CT surgery, our nurses, of course, uh, 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 and our pharmacist and nurse practitioner in general cardiology. We've had barriers and challenges. Initially, there weren't mechanisms to identify patients with pericardial disease prior to them arriving in our general cardiology clinic. So we've had to develop methods to screen and route patients. We've also had continued to have challenges with just limited physician time, competing with general cardiology, the rest of general cardiology for time. And then it's taken some time to identify for folks without a specific interest in this to become more and more aware of the need for this sort of focus and to develop interest in this. And so identifying interested colleagues in other sections or divisions who have an interest in this has been an iterative process and one that has we continue to develop. And then we've had to grow our experience in managing patients on biologic therapies and also continue to standardize imaging practices. That remains a challenge as well. We have additional continued challenges, and particularly in growing our research program and in creating more rigorous methods for tracking and monitoring our patients and standardizing care pathways. We have succeeded, and I think in many ways, in developing a local pericardial diseases center. Initially started out as my own personal interest in this area to clearly a growing multidisciplinary program, and we've definitely succeeded in developing relationships both locally and nationally to make this possible and participation in national initiatives. And we've also, the key in this has been collaboration across with multiple providers and additional other disciplines, and beginning to standardize our office and care pathways. And we have also benefited from our engagement with the American Heart Association along the way. And I think for centers who are similar, looking to do something similar, I think continually engaging others in connected fields and making aware of your interest and developing relationships with potential partners is key. And continuing to communicate more and more about the need for this locally, regionally, and nationally plays a major role. Definitely we have succeeded, I think, in developing a nascent pericardial disease center at our institution. It's definitely possible within a small to medium-sized academic medical center, but it definitely requires a team, and none of our success would have been possible without the team that we have. My hope is that, and my strong belief is that this sort of model is something that really benefits patients and will continue to benefit patients with complex pericardial disease. Thank you so much for your time, and happy to take questions later on. And with that, I will turn it over.
Thank you so much, Dr. German, for sharing your journey. As a reminder to our attendees, please feel free to type into the Q&A function any questions along the way, and we will collect those and ask those questions at the end of our webinar. Taking a turn, I would like now to introduce our next two speakers, Dr. Dor Lotan. Dr. Dor Lotan is an advanced heart failure cardiologist and serves as the medical director for the Center of Pericardial Diseases and the New York Presbyterian Enterprise Centralized Heart Failure Management Program. He has over a decade of experience in pericardial diseases, having trained in Israel under mentorship of world leaders in the field before joining the faculty at Columbia University Medical Center. Dr. Lotan has contributed to multiple clinical trials, pericardial research, book chapters, and international collaborations, working closely with experts worldwide to advance the care of patients with pericardial, myocardial, and heart failure syndromes. He also serves on the board of directors of the Myocarditis Foundation and is an associate editor for the American Heart Association's Circulation Heart Failure Journal. Next, we have Jordan Lindekins. Jordan is a heart failure and transplant nurse, practitioner, and co-director of the Center for Pericardial Diseases at New York Presbyterian Columbia University Irving Medical Center. She has developed focus and expertise in heart transplant, pericardial diseases, advanced heart failure, myocarditis, and rheumatology disorders, with a special interest in immunology and innovative care delivery models for complex cardiovascular conditions. She trained at the University of Pennsylvania and has contributed to research in heart transplantation, cardiorenal metabolic outcomes, and care delivery frameworks, with work presented internationally at the International Society for Heart and Lung Transplantation and nationally at the National Lipid Association. It is my pleasure to now turn it over to Jordan.
Thank you so much for that introduction. It's so nice to meet you all. I'm Jordan Lindekins, nurse practitioner. Dr. Lotan and I were a part of the team at Columbia Center for Advanced Cardiac Care. We worked with advanced heart failure and heart transplant patients when I was presented with the opportunity to establish a pericardial center with Dr. Lotan. It took a lot to go from sitting down and envisioning our center to get to where we are today, but we're so excited to share our model and how it's evolved over the past 2 years. Of course, I first need to tell you how we are located in New York City. We're in a large metropolitan academic medical center. New York Presbyterian Columbia not only has New York City clinics, but also expands over Midtown and Westchester. We have over 400 clinics actually, and 8 hospital centers. Our location is unique because it's located in the heart of the tri-state area. We get patients from Connecticut, from New Jersey, Pennsylvania, and of course, New York State. Because of where we're located in New York, we have a very diverse patient population, and our center has a cumulative enrollment of 850 patient visits within the first 16 months. So now going into the pericarditis sort of introduction here, the burden of this disease is significant. Nearly 160,000 individuals are affected by pericarditis nationwide. This is about 5% of emergency room visits for non-ischemic chest pain. These patients are complicated. They require specialized care centers to which access is variable. These centers need, as Dr. German mentioned, expertise in multimodality imaging and collaboration with rheumatology, cardiothoracic surgery, so that we can deliver the highest quality care to these patients. Thankfully, the AHA has this initiative that includes the 18 healthcare champions so that we can improve access to care for pericarditis patients. And we're really happy to share our model with you guys today. Our objectives are to describe the development and implementation of a dedicated pericardial disease center. We want to highlight our infrastructure and our standardized workflow. We're going to present our workflow and our referral pathways and our models to you guys to show how we have a timely diagnosis and comprehensive management of these patients. And we want to share our lessons learned with you all from our experiences so that it can inform the establishment of similar specialized programs at other centers. So the first step is to sort of describe our cycle, right? The patient comes in, we we gather their data, we hear their story, we review their history from prior records and other intake forms they might have completed. We really try to have at least a same-day echo and an MRI within approximately 2 weeks, but ideally before the visit, so that we can sort of incorporate that diagnostic information, as well as labs, checking inflammatory markers. If there's concern for constrictive physiology, we may need a left and a right heart cath to assess the patient's hemodynamics, or even a cardiopulmonary exercise test as well. So we really try to have trusted MRI readers, trusted interventional cardiologists that are going to be performing our caths, and as well as close relationships with rheumatology and cardiothoracic surgery. Again, if there is signs of constriction that they might need to be consulted. So we sort of gather the data through talking to the patient, hearing their story, gathering their diagnostic data, and then sort of consulting and collaborating with our other team members in other fields, and sort of then create a treatment plan that's tailored to the patient, so that we sort of get this in a timely manner and sort of follow standardized care, using guideline-directed medical therapy, but also, tailoring each patient's plan based off of their case. For the purpose of this initiative, we did conduct a needs assessment. We wanted to make sure that we had a strong infrastructure with excellent support from our group in order to be accessible and accommodate a large influx of patients. We established workflows, which we have a slide coming up that we will share with you. But we did collect data not only for our own research purposes, but to use our outcomes data to further guide evolutions in practice and to reflect our progress to leadership to leverage more support to continue our further growth. This figure sort of demonstrates, as expected, when we started in March of 2024, our new patient curve, it shows that we've had a steady incline of approximately 20 new patients per month. We've now reached over 1,000 patient visits with roughly 350 patients with recurrent pericarditis. As you can imagine, it takes a village to grow this center, and this is sort of like the peak of our model. So to get into that a little bit further, this is our deep dive. So to start, we'll break down, internal and external referrals. So starting with inpatient sort of consult service, that's something very unique to our practice. Anybody within our enterprise, whether it's at one of the 400 outpatient clinics or within one of the 8 hospital centers, they can reach out to us, send us a message and ask us to sort of see that patient while they're admitted. We saw that there was a large influx of people reaching out to us. So we wanted to create an EMR referral system so that people from anywhere could put in a referral and get that patient seen as soon as possible. Then with this large influx of referrals, we needed a structure to sort of manage and accommodate and triage these referrals. So we have a call center, we have our own schedulers, and we have dedicated new patient slots that we try to see our patients, especially if they're in an active flare or have acute findings with their clinical data. We really try our best to see them within 2 weeks of that referral, or even sometimes the next day if they're really concerning us. So another layer of this triage is our intake form. This intake form is for the patient to fill out and give us basically the information that they find relevant to their past pericardial or just cardiac history. We have a dedicated email that they can send this to, our Pericard email, and they can also submit their records, their reports of their echo, their MRI reports, and describe their history to us and send it to us via email. We also have a website, so that sort of creates awareness of our program, but also sets expectations for patients so that they know what's basically going to happen when they come see us in our clinic. Then over to the external side, we do some reach out via, social media or nonprofit foundations, specifically with the Myocarditis Foundation and the Pericarditis Alliance. We do reach out to local clinics to create relationships and have those external referring providers. We understand that these patients, again, they require timely scheduling of tests and diagnostics, and we wouldn't be able to do this without the help of our admin, scheduling, and our additional nursing staff. We really like meeting with our multidisciplinary team to sort of understand and identify complex cases. This is an excellent learning opportunity for the entire group. So in order to sort of, accommodate all of these patients, we needed more clinic space. The way that we did that was by having a dedicated virtual day for patients who we could follow up with virtually in between inpatient visits, and also, an independent nurse practitioner clinic to maximize follow-up opportunities and keep our clinic open for high acuity new patients, again, that we're trying to get in within that 2-week window. So, on top of all of this, we try to spend a lot of time on education and outreach regarding our process. We have a research department to review our data in order to contribute to further science in this field. We attend conferences and try to stay up to date on guidelines and collaborate, as I mentioned, with other specialists, whether that's rheumatology, infectious disease, immunology, cardiothoracic surgery. And we also met with our marketing department so that we could maximize opportunities to reach more patients in need and create awareness of our program. So that was a lot. Let's recap. With this model, we have seen that our regularly available clinic has allowed us to maintain a steady increase in monthly referrals. This has demonstrated a sustained growth trajectory. Through our network building and our educational activities, we've been able to expand through referrals, and we've received national awareness of our growing program. When we started, we would see 10 to 15 patients in one clinic day. Now we're seeing 20 to 25 patients and, utilizing advanced practice providers to maximize that follow-up opportunity. We hope that by sharing this deep dive into our model, we can demonstrate the reproducibility of this model and how you can have success in scaling your pericarditis center upwards. So with that, I'm going to turn it over to Dr. Lotan.
Thank you, AJ, for hosting us, and thank you, Jordan, for that wonderful breakdown and overview of our center workflows. I'm very excited to be here among amazing people through the AJ and clinician. So as you can see, very early in the design of our program, we recognize something important. So once you truly address an unmet need and you do it well, the demand will come. And if you are not prepared for that influx, access to care becomes the limiting factor, not the expertise necessarily. So because we practice in a very dense urban environment and access was central to our strategy from day one, so rather than building a single centralized clinic, we made a deliberate decision to scale geographically and meet patients where they are. So today, we see patients across 3 strategically chosen locations. We have a midtown site positioned near major transportation hubs to facilitate easy access for patients traveling from across the city and region, and it's a midtown Manhattan. We have our uptown location at the main campus, which anchor our multidisciplinary care and advanced diagnostics if need. And we expanded north to Westchester, specifically to support patients coming from upstate New York and neighboring states who prefer not to travel into Manhattan. As a result, while our core patient population come from New York, New Jersey, and Connecticut, we now routinely care for patients from Vermont and across the East Coast, expanding as far as Florida and even beyond. So this geographic scale, paired with standardized care model, allows us to grow rapidly without sacrificing quality, continuity, or patient experience. If you go to the next slide, and perhaps, most importantly, we learned very early that you always need to be ready and you need to choose the right tools. So pericardial disease is inherently complex. It goes well beyond acute idiopathic recurrent pericarditis. So once our program launched and the referral partners saw that we were comfortable managing complexity, they began sending us patients with unclear diagnoses, not just straightforward cases, as you can imagine. And that required the provider, us, to feel confident navigating alternative etiologies that may initially present as idiopathic pericarditis or simple effusion, but ultimately turn out to be something very different. You can see here, such as myocarditis with myocardial involvement, infiltrative cardiomyopathies, autoimmune or autoinflammatory diseases, and other systemic conditions. Equally important is having access to a clearly established pathway for advanced diagnostics. Providers need to be comfortable not only ordering these tests, but also interpreting them, applying the result clinically, while allocating resources based on the specific disease process. In our practice, cardiac MRI, echo, and comprehensive laboratory testing form the foundation, but in selected cases, we routinely escalate to nuclear imaging, stress testing, and invasive hemodynamic assessment and left and right heart cath when the clinical questions demand it. So the bottom line, we need to prepare whatever comes on our way. And if we don't know, if we're not sure, we need to use our resources as a multidisciplinary approach to get the patient the right solution. Next slide. So this slide really integrates how we think about pericardial disease, not as a single diagnosis, but as an integrated, layered spectrum of care. At the center, you can see these stacked layers. They represent the reality that pericardial and myocardial processes frequently overlap, evolve over time, and require dynamic reassessment rather than a one-time diagnostic label. Starting on the left side of the slide, we anchor in classic pericardial pathology. This includes acute, recurrent, chronic pericarditis, followed by pericardial effusion, whether incidental, idiopathic, post-surgical, malignant. But as disease progresses or persists, we move into a different era or a different complication, maybe constrictive pericarditis, which can be transient, chronic, or burned out, and often require both non-invasive and invasive evaluation. And in the far end of the spectrum, we frequently encounter a patient who coming in for pericardial mass, cyst, can be benign, can be malignant, can be primary or secondary. So we definitely need to feel comfortable when anything comes on our way. On the right side of the slide, we really want to highlight the myocardial and systemic layer that frequently intersect with pericardial diseases. This includes myocarditis, as well as overlapping syndromes such as myopericarditis and perimyocarditis. We also see a strong interference with autoimmune and autoinflammatory disorders, where systemic inflammation directly drives the cardiac involvement. So finally, cutting across all layers is clinical trials. For many of these patients, particularly those with recurrent and refractory disease, access to clinical trials allows to offer emerging mechanism targeted therapies rather than a stepwise empirism. And the key message here is that the scalable pericardial care requires expertise across all of these layers and the ability to move fluidly between them as the patient biology evolves. You can go to the next slide. And definitely, we are very proud. Pericardial disease is a true team sport. There is simply no way to build or scale a successful pericardial center without an extraordinary team that we have. I could not do this work without the dedicated, motivated, and deeply committed people you see on this slide. This team truly reflects the importance of multidisciplinary management, especially for disease processes that really sits in this intersection of multiple medical disciplines, most notably cardiology, rheumatology, but it goes beyond. At our core of our center, we have a dedicated cardiology team composed of physician, myself, Dr. Batra, a nurse practitioner, Jordan, who you just met, who co-direct the center with me, and Jillian, our nurse, who help us to manage the longitudinal care of this patient. Surrounding that core are champions in rheumatology, cardiac imaging, and cardiac surgery, experts who are deeply engaged and consulted as needed based on the underlying etiology. The message here that what makes this work is not just having access to these specialties, but working hand in hand. We navigate complex and evolving disease courses together through scheduled multidisciplinary meetings, dedicated imaging discussions, and clearly defined internal referral pathways that allow us all to escalate care efficiently and thoughtfully. And by working with these dedicated champions rather than ad hoc consultants, we were able to build a level of shared expertise that does not improve patient care, but also elevate our collective knowledge across disciplines. You can imagine, me, a cardiologist, when I just started, I didn't know much about rheumatology beyond my medicine rounds. But definitely working with this team hand in hand, it definitely made us cardiologists more aware of rheumatological process and our threshold to diagnose and referrals just much, much better, including imaging. And that team-based foundation has been absolutely central to the success and growth of our center. So now I want to move back to Jordan to walk us through our steps to success.
Thanks, Dor. So looking back, we established this model. We had a large influx of patients, but we had to find a way to manage the significant need while maintaining high quality care and best practices. We have found that these identified practices that we've shown you on this slide are the ways that are unique to our model and has helped us to level up to get to where we are today. So, a lot of these we've referred to, but having trusted collaborators in imaging, pharmacy, rheumatology that really understand our thinking and workflow is very key. As we said, the new patient slot 2-week rule helps establish trust with our patients and show to them that we are accessible and that we understand what they're going through and that this needs to be done in a timely manner. Along with that sort of accessibility theme, we have a call center that's staffed with a covering provider 24/7. We have nights, weekends. We advise our patients to call immediately when they're experiencing a flare. For those international patients or patients that are coming from further away, we have patient services to help us accommodate them and sort of get testing done ideally same day as the visit. We have the intake form because these subtle details that the patients share with us really guide our practice and our care and help us to take our standardized plan and tailor it directly to that patient. We need to remember that a lot of the work happens before we even see the patient. So these records and intake forms help us to sort of anticipate what we'd like to do while understanding that these details in the patient's history are also key and sometimes don't come up until we speak with them face to face. Finally, from an NP perspective, the physicians in our practice are incredibly busy. They have other clinical and leadership responsibilities. They aren't able to see every patient every day. So the NP independent clinic has been really key for our practice to offload the follow-up demand. And, it's helped us to see that, our new patients are coming in as soon as possible. And you see the little life raft that Dor put there in the visual with the NP clinic. So that's really helping keep us afloat. I'm going to hand this over to Dor to talk about our experiences over the past 2 years.
Yeah, so we are one slide before the end, and I want to end by briefly reflecting on where we started and where we're headed. And definitely I welcome all of you to leave questions in the Q&A, and we'll be happy to address all of them, including with Dr. German. So at the center of this figure are our initial challenge. Like many programs, we faced staffing transition, limited awareness of pericardial disease as a subspecialty, constraining clinic space, especially in a place like Manhattan where real estate and space is pretty limited, scheduling limitation, and the need to build standardized protocols essentially from the ground up. As we work through those foundational layers, the focus shifted from survival to growth. One major priority has been expanding our research effort, developing prospective registries, increasing precipitation in clinical trials, and systemically capturing patient-reported outcomes, but not just for research, also to go back to leadership and get more resources and support as we grow. In the beginning, when we brought up the idea of a Center for Pericardial Diseases, definitely we didn't have enough support. Leadership came to us and basically asked us to bring back numbers and to see how much the institution, which he did in the end, can support us. So building up these databases, counting the numbers, getting the patient perspective and feedback was initially essential to our growth. In parallel, We're actively strengthening multi-center and multidisciplinary collaboration, which is a key in managing pericardial diseases. The goal is to harmonize best practices across institutions and ultimately optimize national care model for patients with pericardial diseases. We definitely do it with the AHA as a recognized champion of the 18 centers across the country and beyond. So we are working with local hospitals, Jordan, myself, going to local hospitals around New York area, giving ground rounds, giving short talks, outreaching, but not just getting patients to our institution, to really educate them how to treat patients with recurrent pericarditis. We're not trying to get more patients. We're trying to offload some patients that may get care in the center that they're coming from. So education across the region and beyond is a key to at least for a better outcome for our patients. And education is another critical pillar. As I just said, we're developing a structured educational initiative to train the next generation of clinicians within NYP with true expertise in diagnosis and management of pericardial disorders. So we have residents and fellows who rotate with us, and we are identifying our key clinicians that will work with us in the following years, and hopefully we choose this career path in cardiorheumatology or cardioinflammatory and work within the Center for Pericardial Diseases, within NYP, or they graduate and go beyond. And finally, we are increasingly leveraging digital health and remote monitoring tools to extend the reach of specialized pericardial care beyond traditional geographic boundaries. This is more like a vision, and hopefully in the near future, using AI, using other technologies, we'll be able to reach even further away and deliver care to our sick population. So while the early challenges were real, they ultimately created the framework that now allow us to look ahead with intention, scalability, and truly have an impact. And I will hand it over back to Jordan for our concluding slide.
So, in summary, this model serves as proof that pericardial specialty centers can evolve into large referral hubs through critical efforts to maintain awareness of guidelines and emerging therapeutic approaches. The key to our success thus far is our organized infrastructure, where each member of the team is aware and plays a part in our standardized workflow that's rooted in expertise in inflammatory cardiomyopathy. Please remember that the community of pericardial disease experts is still small. Collaboration amongst all of our colleagues in this field not only will facilitate better patient care, but will increase each of our own awareness of what's going on in the field. We'd like to thank you all for listening and for the AHA who drives this initiative, understanding that a specialized care center is needed, even for a fairly common, although overlooked condition. Most importantly, we'd like to thank our patients who gave us trust and fueled their passion to build this Center for Pericardial Diseases.
Thank you so much, Jordan and Dr. Lotan. We really appreciate your fantastic presentation and the fact that you were able to so eloquently share your insights and successes in managing these complex processes and for the better of your patients. So now we can turn over to the Q&A session of our webinar. I'd like to introduce my colleague, Kelsey McCauley, who will moderate this session. Kelsey, I'll hand it over to you.
Thank you, Sue. Excited to dive into a little more conversation with both Dr. German, Dr. Lotan, and Jordan here. So one question I think the first one we have is for Dr. German. I know the Columbia team had touched a little bit on kind of how they triaged their internal versus external referrals. Could you maybe touch a little bit on the process you have at OHSU for kind of looking at both your internal and external referrals for recurrent pericarditis?
Right. So for OHSU system is a little bit smaller than Columbia. We have two hospitals in our system, and then we have we have kind of a separate process for our inpatient referrals or patients who are seen inpatient or subsequently getting established outpatient. Those patients, honestly, it's a word of mouth as well as a paper refer, a digital referral. So that is, there's awareness of our program within our cardiology division, and the cardiologists within our system, as well as the fellows, help facilitate referrals, so for patients seen inpatient. And then internal within our primary care networks at OHSU, those referrals are handled pretty much the same as our external referrals for outpatient to outpatient referrals. There's a document, a referral document with in every case that specifies the reason for the referral, and those are reviewed by our schedulers. In most cases, they'll successfully identify the reason for the referral being for pericardial disease and make sure to place the patient in the correct location.
Thanks for sharing that. That's great to know. This is a question for kind of both centers to answer here. Is travel to your center an issue for patients in rural areas? And how do you ensure continuity of care when they return back to their PCP or general cardiologists?
Yeah, I'm happy to jump in and take the question. So definitely, it's a very good question. And the challenge that we are facing from time to time, some of our patients are really traveling out of state, flying in within the US and beyond. And the problem is once they go back to their state, we are not allowed to do any virtual visit with them, definitely because we're licensed only in New York in the tri-state area. So definitely, once we identify a patient, for example, who came in from Florida, we just had recently a patient coming from South America, we are trying to help them to identify a pericardial expert locally that we can work with, or at least a cardiologist that we can work with. So we come in, we do the care we need, we give the recommendation, they go back to their home state, and they are establishing a care with the local cardiologist that we are communicating with him, guiding him through. And definitely if the patient want to come to see us again, then many of them they will fly again back to New York to see us for additional recommendation. But as I said, also our team is kind of trying to get more and more licensing. So now we are, for New York, Connecticut, New Jersey, Pennsylvania, and slowly we kind of expand more and more with the need, and hopefully to can provide more virtual care for these patients.
Yeah, we have similar challenges at OHSU. We have a large geographic area we serve. Even within Oregon, sometimes patients are driving 6 or more hours just to come and see us, and so we do deliver care here, but we also provide a virtual care for follow-ups, but yeah, it remains a challenge, and we do work with our try to make sure the patient's working with a local cardiologist when they're coming, especially when they're coming from far away.
Thank you. And I think to add on that too, what strategies have you guys found successful in building those relationships with community providers? Whether that be bringing awareness to your program or, facilitating that transition of care, what strategies have you found successful? I know Dr. Lotan, you mentioned, doing grand rounds out in the community, but, I'd love to hear if there's other strategies that you guys have to bring awareness to this program.
Yeah, 100%. It's a challenge, and we learned very early in our process that we are identifying ourselves as a consultant service. Especially when we are getting a referral from a local cardiologist who definitely want to continue to take care of this patient and to continue to do imaging on labs locally in his own practice. So some concern that some of these providers had in the past, that once they get into Colombia or to our healthcare system, we're kind of taking them away from the local cardiologist, but it's the other way around. So now we have a trust system within a lot of our referrals. And I can tell you, we get referrals from local large healthcare system across New York. They're coming to Colombia just to see us, but let's say, and they go back to their own healthcare system to do the imaging, and definitely we can get the CDs, we can review it in our end. But we are trying to really to make sure that everyone feel comfortable that we are just providing a consultant services to them, and the patient may continue their care with their referring provider.
Yeah, I think this is also very helpful for initiating the biologic therapy. Sometimes the patients want to go on it, but their local cardiologist maybe doesn't know how to sort of establish a workflow to get that patient the medication in a timely manner. So a lot of the outside providers will refer to our patients to us to just be evaluated to see if this is even a possibility. We get them on the medication, and then they come to sort of check in from that perspective. So we collaborate with them. The day-to-day sort of stuff maybe goes to the local cardiologist, but we can still help with that medication access.
I think we have a similar model, and we try to utilize outside imaging as much as have the patient have their imaging done elsewhere, wherever they're coming from, and we always try to review and take advantage of whatever has been done elsewhere, and encourage continued follow up with the local cardiologist, primary cardiologist, and uh, and yeah, so that's that. I would say things are similar from my perspective.
Great, thank you. What evidence sources most influence how you've built your models and really guide your clinical decision making?
I think for me, it's just been certainly that the recent guidelines from the American College of Cardiology have been helpful, but along the way it's been because there haven't been clear U.S. guidelines. It's been a process of reviewing just a lot of original research and speaking with colleagues around the country, and then also locally, as well as so there's a lot of within the pericardial disease space. There's a lot of expert opinion and experience that's useful. So it's always helpful to talk to people. There's a lot of unusual conditions we run across, and so it's always helpful to talk to people who have experience managing those conditions. In addition to just reading, even case reports and case series and old just original papers, and just building experience also with therapeutics, particularly reviewing clinical trials, and um, as well as the European guidelines.
Yeah, I agree with you, David. And I would also add that nowadays in this era, we feel there is a paradigm shift of how we are looking at patients with pericardial diseases. In the past, not so long ago, I would say 5 to 7 years ago, we were treating patients with the first or second line therapy, and that's it. We were waiting for them to flare up, and then we were treating them. And now with emerging science, data, drugs, pharmaceutical company, community support, clinicians, research, and beyond, we learn that we need to change how cardiologists think. We need to change our mindset, not waiting for the next flare, and maybe to treat them with more sustained therapy in some cases, to keep them for longer we can at remission. And I'm not just talking about pericarditis, I'm talking about autoimmune disorders and autoinflammatory disorders, and to really how cardiologists need to think a little bit like rheumatologists. And this area of pericardial disease really falls between these two disciplines, and very frequently is fall between the cracks. So as you mentioned, with the ACC, the ESC, and other large data sets and reports, we kind of need to educate ourselves. We need to attend meetings. In the end of the day, we are a relatively small group of experts across the country who is dealing very frequently with pericardial diseases, and we are all very good friends and collaborate on many other projects, which make the success of each individual center. So I can call David and ask him a question about a patient that I'm not too sure what to do, and then he will call a different colleague the next week. So I think to keep this community close together, but also to make sure that we are educating the rest of the country is a key element how to treat patients with pericardial diseases.
Yeah, that's wonderful to hear. I just have a couple more questions here. The last one I have here is what quality metrics are you tracking in your institutions, and how do you share this within the multidisciplinary team?
We're just starting to build our ability to do this. I mean, we have not had a very well developed sort of a registry of our patients, and we're just developing this now. So Um, uh, and so right now, not a whole lot, but we're trying to just track all of our patients so we're not losing any to follow up. And we have a running list, but I don't know that we're doing a whole lot of like specific quality metrics right now, to be honest.
Yeah, at least on our end, and Jordan, please step in, but we are definitely collecting the data. And I think one of the things that you learn very early when you're looking at patients with cardioinflammatory disorders, they are very active on looking on finding the right provider. So by the time they see you, they already saw 4, 5, 6 providers. They're going beyond states until they find the right center. So I think them coming back, this is the first quality metrics to understand that, A, we are on something, patients feel comfortable, we are on the right path to get therapy. And definitely we're collecting our data of the number of flares or episodes before or after establishing care with the pericardial center. This is something that we are collecting very meticulously, and hopefully we'll be able to publish this data, at least our own single center in a large metropolitan area pretty soon.
Yeah, we keep a patient list, not only for what their diagnosis is, but if they're on, an IL-1, we keep it sort of a timeline of what was the cause of their recurrent pericarditis, when they started it, and what plans we have for the future for them, whether that's some sort of clinical trial that might be going on or a weaning process. So we sort of have like a timeline of how to look out for the next patient. So we have them in order of chronological start dates, pretty much. So then we know who started when and keep track of them in that way, which I found to be very helpful.
I think as we wrap up here too, one thing, if you guys could elaborate on a little bit how you integrate your NPs into your pericardial center with patient education, injection guidance, and nurses. I don't know, Dr. Lotan, if that's just a comment or you want to elaborate on that a little bit more, but I think that that's really something, key to the multidisciplinary approach that, if you want to elaborate any more on, we're happy to hear.
Yeah, definitely. And we'll let Jordan to take the heavy lifting here because she's the true champion of this center. For sure. But I would say that, as a cardiologist, a heart failure cardiologist, and, I believe any cardiologist or provider who tuned into this webinar will relay that, we are very busy. We are spending our time from cath lab, from imaging to rounding service, outpatient clinic, things that are other than pericardial diseases and other leadership roles. And definitely when taking care of patients that have a high touch point population. So it doesn't mean that we need to make sure that the infrastructure and the structure of our model can actually accommodate them. Because patients with recurrent pericarditis, just for an example, require multiple touch points, at least until you get them to the right therapy. And then you need a very meticulously follow-ups for at least 3 to 6 months. So if I would do everything by myself, I would not be able to do any other things that I'm leaning and committed to do to my institutions. So I partnered with Jordan, who worked with me from day one of these centers. And for me, it was easy. But we also have Jillian, for example, a nurse who worked with us very closely, who coordinate everything together with us. So she is educating our patient with injectables. She monitors side effects, drug interaction, sending labs out, genetic testing, working with our group just to help and offload Jordan and me to facilitate this influx of patients that we encounter after inception of our center. But Jordan, I'm happy to hear how you see it from the nurse practitioner side.
Yeah, I think a few things that are really helpful on sort of the backside of things behind the clinical sort of space is coordination of care. Collaborating, so making sure that the outside referring provider, if there's a rheumatologist involved in the patient's care, making sure that we're touching base with them so that we're not just sort of talking to the patient and the patient's like bouncing back between providers. So I think that that's one thing that's key. The other thing is with the IL-1 medication, we meet with the patient care liaison to make sure that patients are getting their refills. We have high alert patients, so patients who maybe flared because they missed a dose or something. So to make sure that they're getting their refills in time, eliminating gaps in their care and in their meds. So I might bring that patient in more frequently or might do a virtual visit in between because I just know that that patient might fall through the cracks. Along with that, something that helps with knowing our and meeting with our patient care medication person is that we know when the patient's going to get their first dose delivered, and we actually try to bring them in within like 48 hours of them getting their loading dose of the medication, because we've seen that the patients who get in-person teaching from Jillian have much better outcomes, just in their own experience. They feel less anxious, they get a side-by-side sort of teaching, right? So Jillian is showing them how to reconstitute a medication or how to self-inject, and then they're doing it themselves as well. So it's that parallel sort of teaching that's really helpful. So those are just a few things, but yeah.
Oh, I'm so glad you hit on that. I think that's really important to share, and something that our audience will find valuable. And I know that brings us to time here. So I'd like to thank everyone for joining this webinar today, and I'd like to thank our speakers. And I believe, if you have questions, please reach out to Sue at Susan Abel at heart.org. Otherwise, we will be sending out a post-event survey, and we ask that you please do complete that, because it helps us to make sure that we're tailoring our education to you guys and giving you content that's valuable. So we'd really appreciate any feedback. Otherwise, thank you so much for joining, and hope you have a great rest of the weekend.